All right. Thank you very much for the invitation. I'm truly privileged to be here in this very prestigious symposium. My name is Ahmed Assaf. I'm professor of ophthalmology at Ain Shams University and shareholder and phaco-refractive surgeon at Al Watani Eye Hospital in Cairo, Egypt. I don't have any financial interest in any of the subjects mentioned in this presentation. LASIK flap creation is one of the most crucial steps, and LASIK is severely compromised without a good flap. Good flap creation requires vacuum to fixate the eye. Vacuum loss or suction loss can be challenging, delicate, and one of the most stressful situations for the surgeon during LASIK surgery. The key in management of suction loss is prevention. And to prevent suction loss, it's crucial to recognize those risk factors that include the pinguicula, pterygium, eyes with prominent eyebrows, large nose, patients with deep-seated eyes, lid squeezers, or pronounced Bell's phenomena. Of course, the surgeon should check the eyelid speculum and make sure that it's widely open, and sometimes we may need to change the speculum. And of course, we have to instruct the patient to open both eyes, especially those patients with pronounced Bell phenomena, and we have to relax the patient by keep talking to them. However, suction loss sometimes is inevitable, and we can categorize the suction loss according to the timeline of flap creation. So suction loss can occur during raster flap creation, or just after the flap creation and just before the side cut creation, or early during the side cut creation, or maybe late during the side cut formation. So let's start with the suction loss during the raster flap creation. As you can see in this case, while the femtosecond laser is running, creating the flap, there is a suction loss. And in this scenario, I'll usually apply my 7S strategy. That includes stop, start again, using the same parameters, same suction ring, same cone, same time, same plane, same everything. It's very important to start immediately in the same settings, in the same time, in order not to lose the characteristic conjunctival shape created after the application of the first suction. So as you can see here, the suction created indentation on the conjunctiva, and we can take benefit of this indentation to apply the second time suction on the same location at the first time. Of course, we have to use the same suction cone. Using the same suction cone and the same parameters, same plane, that may ensure the same depth for flap creation, because after applanation of the cornea, theoretically, because we have used the same glass cone, the laser will start or will continue the flap creation in the same plane. So as you can see here, I have applied the same cone using the same parameters immediately after I recognize the suction loss, and start all over again for flap creation. And as you can see, the flap has been created again almost on the same location like the previous one to complete the surgery, and we can proceed later on with the flap lifting and without any consequences, and we have a decently smooth bed ready for excimer laser firing to correct the refractive error. Now let's talk about the suction loss after flap creation, but just before the side cut creation. Here in this case, we can proceed for the side cut formation, but after modifying the laser energy for the bed. With the femtosecond FS200 of wave light, it does not allow to cancel the laser energy for the bed formation. So here, I'm using the same settings, but I have just modified the laser energy for the bed formation to reduce it to the minimum. So I have reduced the laser energy towards the minimum, which is 0.1, and increased the spot separation toward the maximum, which is 12 micrometers. And of course, I have the option to cancel the canal formation because the canal has been already formed before during the first application. So this is the second application of the suction ring after the suction loss of the first time, and the flap, the bed has been already created, but the side cut is not formed yet. So applying the same settings, except the laser energy for the bed is reduced to the minimum. Now the laser is been firing, forming the bed, but you can see nothing because the laser energy is too weak and we cannot see it, and you can see only the laser energy during the side cut formation. And now we can proceed and move forward for flap lifting again without any consequences, and we can have uneventful LASIK surgery as nothing had happened before. Now let's talk about the suction loss during the side cut formation, but early during side cut formation. In this case, because the side cut formation was incomplete, I would recommend to do another side cut, but with a smaller flap diameter. So again, reduce the laser energy for the bed formation, cancel the canal formation, keep the laser energy for the side cut at the same, but reduce the flap diameter from 9 millimeter to 8.5 millimeter. So here I have manipulated the laser energy and reduced the flap diameter, applied the same cone, and again here, after applying the suction ring and the glass cone on the ocular surface, applanation of the cornea, the laser is being firing now, and there you can see nothing because the laser energy for the bed is reduced toward the minimum. And now this is the side cut. The new side cut has been formed within the incomplete original one. And after removing the side cut, the suction cone, you can see this is the newly formed side cut of smaller flat diameter within the borders of the incomplete flap or incomplete side cut from the first application of the applanation cone. And we can proceed forward for LASIK formation. And finally, let's talk about the side cut formation late, or most of the side cut has been performed, but maybe 1 or 2 clock hours was incomplete because of something was obstructing the laser energy, or the laser energy was not enough, or maybe the suction loss has occurred just late before completion of the procedure. Here we can move forward for flap lifting. We may need to use some extra mechanical force to cut those corneal fibers at the site of incomplete side cut formation, and then we can proceed for LASIK surgery in the usual way. So in my conclusion, suction loss can be a potentially visually threatening LASIK complication, however, can be avoided by understanding the underlying causes. Management include stage dependent, and the correct timing and modification of the laser energy are crucial. Safety of the patient is of utmost importance, so surgeon may abort or delay the procedure, or may convert to surface ablation or other form of refractive surgery. Thank you very much for your attention.